It's a pleasure for me to introduce Dr. Christopher Kramer, who serves as the Chief of the Division of Cardiovascular Medicine at the University of Virginia and also as Vice President of the ACC for 2024 to 2025. Dr. Kramer, it's great to have you here today.
Thank you so much for inviting me. It's a pleasure and honor to be here with you.
First, could you highlight the key points of the new hypertrophic cardiomyopathy guidelines 2024 and what prompted the necessity this updated version?
Yes, there were three key updates to the 2024 guidelines over the 2020 guidelines that just came out 4 years previously. The first and arguably most important was that the direct myosin inhibitors were, for the first time, the first one, mavacamten, was approved in 2022. And the uptake has been initially slow, but then more rapid. These are excellent agents to treat obstructive HCM. They're now in the guidelines as a second-line agent after beta blockers. So patients should be on beta blockers if they can tolerate them, or calcium channel blockers. These are patients with obstructive HCM, of course. And then the mavacamten can be added on top of them. At our institution, we have over 70 patients now on mavacamten, and they're clinically doing very well. We've had to stop at 1 or 2 because of a drop in EF. Often that's associated with AFib with rapid ventricular response, and then they can stop and get their AFib treated and go back on it. So that was the first important addition to the new guidelines.
Yeah, it's okay. What were the interesting commentary? I'm sorry. What role does cardiac MRI play in the comprehensive assessment of patients with HCM?
Yeah, so CMR has evolved a very important role in the assessment of the patient with HCM. Number one, it's the most accurate way of assessing the morphology of the HCM, which can be important prognostically. And as the Hypertrophic Cardiomyopathy Registry, which I'm co-principal investigator of, evolves, we think morphology may have an important prognostic role. So that's number one. But most importantly, CMR identifies scar in the heart. And we've learned that about over 50% of patients with HCM have any scar as manifested by late gadolinium enhancement, but that it's the extent of scar that's most important prognostically in terms of predicting sudden cardiac death. In the 2024 guidelines, the cutoff for the amount of LGE as a predictor of sudden cardiac death and an indication, a 2B indication may be considered for an ICD, is 15% of LV mass. So 15% of the entire left ventricular mass subtended by scar. We think over time that threshold may be lowered because there's emerging data and meta-analytic data that suggests that 10% of LV mass may be a better cutoff, but time will tell. We'll have to wait for the next set of guidelines. I meant to mention as well the other two important additions to the new guidelines is one, yearly AFib, prolonged AFib monitoring in patients with HCM, and liberalization of exercise limitations in HCM. It's recognized. There was a large study showing that even vigorous exercise is safe in HCM. So for years we had counseled patients with HCM not to exercise. Now we are allowing them to do more exercise.
And talking about CMR, what tips and tricks would you recommend for evaluating the CMR findings in cases of HCM?
Yeah,
tips and tricks.
Yeah, the most important thing is to accurately assess the quantity of scar, and that can be tricky. The most validated, well-validated measure is a quantitative measure using what we say 5 or 6 standard deviations of the signal above the noise in normal myocardium. That's been validated against myectomy specimens. The problem with that often is that there is no normal segment in HCM. And the software programs are a little bit buggy, and it can overcall the amount of scar. So what I train my fellows and have tried to spread more broadly is that the human eye does extremely well at picking out replacement fibrosis, bright white scar on a late gadolinium enhanced image. And that's the LGE we're talking about. And we're in the process of writing a guideline document for the Society for Cardiovascular Magnetic Resonance, and that's what it's going to say, is that start with your eye and trust your eyes to pick out a bright scar.
Oh, well, that's interesting. And looking ahead, what role do you believe artificial intelligence and machine learning will play in the future of HCM diagnostic?
Yes, I think, certainly already now we have software that does automatic, semi-automatic quantitation of LV mass, of LV volumes, ejection fraction. So that's already here. An area that we've worked in collaboration with the group at Oxford as part of the Hypertrophic Cardiomyopathy Registry that Stefan Neubauer and I co-manage is something called virtual native enhancement. So what that does is could potentially down the road replace the need to give contrast, gadolinium contrast, and do late gadolinium enhancement. So what it does is using AI, combines cine imaging and T1 mapping, superimposes those images on top of each other, and creates a virtual enhanced image. So and we published this in Circulation 3 or 4 years ago. So that it's equivalent in some ways better than the acquired LGE image. And so we think that this virtual native, and it's been validated also in ischemic cardiomyopathy. So we think that this may be a way to avoid the need to give gadolinium and perhaps to make the acquisition faster and avoid the low, albeit still present risk of giving gadolinium.
Okay. Well, thank you, Dr. Kramer, for sharing your expertise with HCM and showing us today. I hope you to enjoy our Congress too.
Absolutely. It's been a great time here in Buenos Aires. Thank you for having me today for this interview and to the conference in general.